Good afternoon, everyone, and welcome back to this afternoon's session of the Australian Ocular Melanoma Alliance Summit for 2022. My name is Mark Shackleton, and I'll be co-chairing this session with Dr. Daniel McKay. I'm a medical oncologist based at the Alfred Hospital in Melbourne, and also have substantial Monash University engagements in the background. One of which is as the current chair of melanoma and skin cancer trials, Australia's cooperative clinical trials group for these diseases. And it's been one of the great pleasures to work with MAST Trials in supporting the ophthalmological, radiation, oncology, etc. communities around the country to form AOMA. And we're really super pleased to work with those guys and the team at ASN to present this third summit. I think we had 1 year off during COVID, but otherwise our intention is to host at least one of these meetings every year. This afternoon's session is going to be switch a little bit to focus more on procedures and issues related to the pathology of ocular melanoma. And we're going to hear from several experts, world-leading experts in this broad field. And it's really the advances in ultimately the advances in the pathology and genomics of the disease and understanding of the molecular biology, the molecular signaling pathways that dominantly drive progression of this disease has led to many of the advances that we're seeing coming through in therapy. So without any further ado, we might drop to the first speaker. It's my great pleasure at the beginning to introduce Associate Professor Matt Carlino. Matt will be very well known to at least the medical oncology members of the medical oncology attendees as one of Australia's leading academic researchers and trialists in melanoma. Matt's a consultant medical oncologist at Westmead Hospital and Blacktown Hospital in Sydney. He's also a clinical senior lecturer at the University of Sydney and a faculty member of the Melanoma Institute of Australia. He's got a PhD, a wet lab PhD background, and is really one of the world's leading experts in these diseases, and has, I think, been one of the major contributors to patients and recruiters of patients to some of the really interesting clinical trials coming through, particularly in the targeted therapy space. So thanks so much, Matt, for dialing in, and we look forward to hearing your talk.
Good afternoon. My name is Matt Carlino, and today, on behalf of the Melanoma Institute Australia, I'd like to introduce to you a number of new patient resources we've developed for ocular melanoma in conjunction with the Australasian Ocular Melanoma Alliance. First, some background about the Melanoma Institute. The Melanoma Institute has the goal of zero deaths from melanoma and is aiming to meet this goal through three pillars. The first is research, the second clinical care, and the third is education. The brochures I'm about to show you are developed within our education faculty. Within education, we have a number of programs aimed at educating clinicians, patients, but also the community more generally. With regards to patient education resources, we have a number of online and hard copy resources for patients with melanoma, outlining a number of different treatments they may undergo, and also some stage-specific data for patients with melanoma ranging from stage 1 and 2 melanoma all the way up to stage 4 melanoma. We've heard from our patients, but also recognise as clinicians an absence of resources for patients with ocular melanoma. As a relatively rare malignancy, it can be difficult for patients to find information, And unfortunately, sometimes when looking up information, there can be some confusion between resources developed for patients with cutaneous melanoma and those with ocular melanoma. And with that in mind, we've developed the resources I'm about to show you. We strongly believe that we can empower patients through educating them about their disease, and we've developed two resource information sheets for patients with ocular melanoma. The first looks at patients with early melanoma, the second, patients with advanced ocular melanoma. The first gives us information about what is ocular melanoma, the risk factors and causes, the potential symptoms and signs that may develop, and how the diagnosis is made. The brochure then also outlines a number of treatment options and also the follow-up care they can get both from their ophthalmologist, but also other members of the team, including medical oncologists and general practitioners, depending on individual cases. There's also guidance where patients can get further information in the future. The second bit of information guided at patients with advanced disease outlines what is the advanced disease, how is it diagnosed, the importance of individual scanning modalities and treatments that are available for advanced disease, including immunotherapies and importantly, the role of clinical trials. Once again, we have direction for patients so they can get more information in the future. So how can you get these resources? They can be downloaded both from the Melanoma Institute website and also the Ocular Melanoma Alliance website. Thank you for the time, and please feel free to reach out to the Melanoma Institute if you require more information or hard copies of these brochures.
Great, thanks very much, Matt, for that recorded presentation, which launches a really important initiative that's come out of the great team at Melanoma Institute of Australia, with certainly strong support and collaboration from the AOMA group. We will, I'll not take any questions about that resource. I think it's pretty clear what it is, and please feel free, as Matt said, to access the information via those online vehicles. I think we'll now move into the main body of the scientific presentations, and it's my pleasure next to introduce Associate Professor Penny McKelvie to give our next talk. So Penny is a career anatomical pathologist who's worked in multiple precincts during her career in Australia and in Queensland, overseas in France, and now for some time in Melbourne. She trained initially as a neuropathologist in Melbourne and then overseas in Boston, and eventually made her way back to the St Vincent's Hospital in Melbourne, where her ongoing areas of interest include neuropathology, hematopathology, but particularly ocular pathology. In fact, she was relatively recently awarded a Doctor of Medical Science in ocular pathology. She really provides an absolutely outstanding and academically orientated service to the docs at the Ionia Hospital as part of our ocular melanoma multidisciplinary team here in Melbourne. So welcome, Penny. Thank you so much, and we really look forward to your talk.
Good afternoon. My brief this afternoon is to speak to you about the pathology of uveal melanoma. I'd like to start with this cartoon, which shows the location of the uvea in the eye. This is the pigmented vascular layer in the eye, which, as you can see in this cartoon, is represented by this pink layer extending circumferentially around the back of the globe, posterior to the retina. This is the choroid. About 90% of uveal melanomas arise in the choroid. As we move more anteriorly, we see that about 6% of melanomas arise in the ciliary body and about 4% in the iris. This is the microscopy of the anterior segment of the eye. This is the cornea, the anterior chamber, and you can see the iris, this pigmented leaflet-like structure, which extends in front of the lens. Then as we move posteriorly, we see the ciliary body, which has two parts. This first pars plicata, which is represented by finger-like projections of stroma covered by pigmented epithelium, which then leads into the pars plana. The anterior chamber angle, as you can see here, is the angle between the cornea, sclera, and iris root. This is particularly important in iris melanomas because the aqueous fluid, which is secreted by the ciliary body, passes anteriorly behind the iris, through the pupil, and then through the anterior chamber into this anterior chamber angle, where it's filtered through the trabecular meshwork and Schlemm's canal. Iris melanomas can tend to clog up this trabecular meshwork and raise intraocular pressure, causing secondary glaucoma. When we look at the back of the eye, this is the optic disc, and this is a retina, which is artifactually detached. Below the retina, we see this pigmented vascular layer of the choroid, which is normally extremely thin. On higher power, we can see the choroid, this thin vascular pigmented layer posterior to the retina and separated from the retina by Bruch's membrane, which acts as a barrier to prevent invasion of the melanoma cells into the retina. Behind the choroid is the sclera. This is a section of a globe which has been enucleated for a malignant melanoma of the choroid. You can see this arrow shows the pigmented lesion, and then this fold is detached retina overlying. This is a whole mount section of that globe, and you can see that there is a thickening of the choroid with this collar stud configuration of a malignant melanoma in the choroid. And overlying detached retina with some subretinal fluid. There are a number of well-established prognostic factors in primary uveal melanoma. All of these factors are associated with a worse prognosis for patients diagnosed with uveal melanoma. This is a table from a recently published article about prognosis in uveal melanomas. You can see that there are a number of factors, including clinical factors such as higher age at diagnosis, male gender, anatomical factors such as ciliary body location and the tumour size, as well as a number of histopathological factors and genetic factors. So I'd like to illustrate some of these. Firstly, ciliary body location and involvement. This is a whole mount section of the globe, the cornea, the iris, and then the ciliary body with the pars plicata, and you see this large nodular pigmented malignant melanoma in the ciliary body. Next, increased tumour size, which is defined by the largest basal diameter and tumour thickness. This is usually measured by imaging prior to enucleation, but we also measure it at the time of enucleation. This is a whole mount globe of a globe with melanoma, and you can see the marked thickening, which is more than 50% of the diameter of the globe. Extraocular spread is another important poor prognostic feature. This is a whole mount section of an optic nerve behind the globe, surrounded by the dura, and this large posterior extraocular tumour extension. Now moving on to the histopathological factors associated with worse prognosis. Firstly is the cell morphology, epithelioid cell morphology. A number of these melanomas are very pigmented, so we perform a melanin bleach to remove the pigment so that we can get a better look at the underlying cells. You can see this large epithelioid cell in the center of the field with a large nucleus and prominent nucleolus. As you can see, after melanin bleach, many epithelioid cells, a poor prognostic sign. Another example, before melanin bleach and after melanin bleach, showing the small epithelioid cells and spindle cells. Vascular invasion, we look at a number of vessels to assess whether the tumour has invaded them, particularly the vortex veins, which are these 4 exit veins at the back of the globe, which we dissect off before cutting the globe. Also, we look at the scleral emissary canals within the sclera. This is a vortex vein. You can see the wall of the vessel, and then this large plug of pigmented tumour with epithelioid cells in the lumen. Increased mitotic count. Cells proliferate, and mitotic index or mitotic count enables us to determine the degree of proliferation. This is a spindle cell melanoma after melanin bleach with this mitotic figure seen. Presence of tumour infiltrating lymphocytes. This section shows, with the yellow arrows, small rounded blue cells with very little cytoplasm at the base of the tumour. At the base of this section, you see this is sclera, and then at the base of the tumour itself, there's this tumour infiltrating lymphocytes. Next, necrosis in non-treated uveal melanomas. This is the same tumour as the lymphocytes, and you can see this is viable tumour at the top and the bottom, and then this area of necrosis. Often these rapidly growing tumours can outgrow the blood supply and the cells die by a form of cell death called necrosis, where you lose nuclear staining and lose the outline of the cells and release of the pigment into the surrounding tissue, where it's taken up by macrophages. Loss of nuclear BAP1 expression or BAP1 mutation. This is a very important prognostic factor and is seen in almost all of the metastasizing uveal melanomas. BAP1 is a gene on chromosome 3, and BAP1 mutation is closely associated with monosomy of chromosome 3 or loss of one chromosome 3 copy. BAP1 mutation can be identified by sequencing techniques or by using a specific BAP1 immunohistochemical mutation-specific antibody. This is an example here. On the left, you see this detached atrophic retina with weak nuclear activity in the nuclei of the cells in the retina, which is normal. And then the tumour on the right, which we see on higher power, completely lacks any nuclear activity. So this tumour has a BAP1 mutation, which is a poor prognosis. By contrast, this is BAP1 wild-type pattern where there is retained nuclear activity, so no BAP1 mutation. Finally, genetic abnormalities, chromosomal abnormalities, particularly monosomy 3 or loss of one of the copies of chromosome 3, gain of the long arm of 8q, chromosome 8q, loss of the long arm of chromosome 6 or 6q loss of the short arm of chromosome 1 or 1p loss. However, you'll have a separate lecture on genomics and genetics of uveal melanoma this afternoon with Dr. Johansson, so I won't discuss this any further today. So I've highlighted a number of the prognostic factors that we look at and report when we're examining globes for enucleation for melanoma. Size, cell type, mitotic activity in 40 high power fields, PS closed loops, rupture of Brooks membrane, invasion of the sclera, of the emissary canals, of the perineural spaces, of the vortex veins, of the optic nerve, and invasion of the anterior chamber angle, and finally BAP1 mutation. Just to illustrate some of these that I haven't already shown, this is a large choroidal melanoma with intact Brooks membrane, this pinkish membrane between the retina and the choroid, which is intact. This is another example where the membrane is discontinuous and tumour has grown up into the retina. A thinner example of a choroidal melanoma, and you'll see a blue arrow down in the sclera showing a vessel with tumour growing in the perivascular space. So this is perivascular tumour extension. On a similar vein, this is perineural tumour extension. This is a small nerve in the sclera with tumour growing in the perineural space. This is a patient with invasion of the optic disc and nerve. You see a choroidal melanoma on both sides of the optic disc. It's ruptured through Brooks, grown into the retina, grown into the vitreous cavity, also extended into the optic disc and posteriorly growing down the optic nerve. You can see there's the nerve fibers of the optic nerve, and then these clusters of atypical melanocytes, a very rare complication. One of the main issues with iris melanomas, even though they're very small, they can invade the anterior chamber angle, as you can see here. There's growth along the surface of the iris, but also growing into the trabecular meshwork and Schlemm's canal. This causes a rise in intraocular pressure and secondary glaucoma. PAS-positive closed loops refers to this proliferation of mesenchymal material, which is PAS-positive, surrounding completely lobules of tumour cells. The Liverpool Uveal Melanoma Prognosticator Online, or LUMPO3, is now in its third iteration. This has been developed to estimate survival probability in patients treated for uveal melanoma. It's based on a variety of factors. Firstly, the anatomical predictors, the largest basal diameter, tumour thickness, ciliary body involvement, and extraocular extension, the histological predictors of epithelioid cells, closed PAS-positive loops, and mitotic count, and thirdly, the genetic predictors, chromosome 3 loss and chromosome 8 gain. And I've tried to illustrate all of these to you today. So at that point, I'll leave you with this schematic of uveal melanoma. Thank you.
Great, thanks so much, Penny. I think Penny's actually online and available for questions. So please put questions into the Q&A box. I think there's a couple there already. So Penny, there's a question here from Amanda Charlton from Auckland. It's divided in two. Let me just try and figure it out. So it says, Penny, our ocular oncologist has asked us to do PRAME, P-R-A-M-E, immunohistochemistry in all uveal melanoma. Can you comment on this when there is already, on the utility of this, when there's already BAP1 loss by immunostaining?
Thanks for the question. I actually don't use PRAME myself. Although it is reported to be associated with a poorer prognosis, we just use BAP1. I know Svetlana Cherepanov at Sydney Hospital, St Vincent's in Sydney uses, but I haven't got any personal experience, so I can't answer that. Maybe Dan or John?
Yeah, I think for patients with retained BAP1, the PRAME is helpful in categorising people into a sort of a good or intermediate prognosis. But I think if the BAP1's already been lost, then it's probably not all that informative.
Penny, Amanda has also asked if you could make a few more comments about 6P and whether or not evaluating for changes in 6P is really useful or not.
I think I might defer that question to this afternoon to Dr. Johansson. He's really talking about the genetics and genomics this afternoon. So I think I might defer that question to him if that's possible.
Good idea. We've got a minute or so left. One of my, I had a quick question actually was, so I think, increasingly we are, I think, likely to be providing you, not with solid pieces of tumour through biopsies or enucleations, but through needle-based sampling of intraocular melanomas. How much of the prognostic information that is required to guide downstream management are you really able to discern from an FNA sample?
I think Rod's going to address that in his next talk, because he's been sending the FNA biopsies for 5 years to Sydney mainly, where they were doing the microarrays. We've only just started doing microarrays in Melbourne. We were previously, the specimens from Melbourne were being sent to Sydney, and I think Rod's going to address that, how much of the prognostic data will be able to be revealed from the FNAs. All
right, well, I better stop asking questions so we can get on to these next speakers and answer them. So I will now throw to Dan McKay, one of our leading ophthalmologist pathologists, dual trained, to take over the session from here. Thanks, Dan.
Thanks, thanks, Mark. So the next speaker is Professor Heinrich Heimann, who has kindly provided a pre-recorded talk for us, being very early hours in Liverpool in the UK currently. So Professor Heimann is the clinical lead of the Liverpool Ocular Oncology Service, where he's worked since 2005. The Liverpool service is one of the highest volume ocular oncology centres in the world. They treat approximately 250 new patients with a diagnosis of uveal melanoma each year. And they have a very broad practice with significant numbers of patients being treated with various modalities, including proton beam, plaque, brachytherapy, enucleations, etc. Professor Heimann is also a very experienced vitreoretinal surgeon, and he's been very heavily involved in introducing the significant role for transretinal and transscleral tumour biopsies in uveal melanoma, where he's worked very closely with Professor Sarah Coupland, one of the world's leading ocular pathologists. So we've asked Professor Heimann to give us some insights on transretinal tumour biopsies. This is a field that we've been gradually introducing into our practice in Australia, so we're very interested to hear his insights on this topic.
Thank you for giving me the opportunity to present our data on biopsies to you today. Basically, biopsies challenge a lot of paradigms in ocular oncology. The first one is almost all diagnosis of uveal melanoma can be made by clinical examination alone. Well, this is wrong. Small melanoma are often diagnosed way too late. Next paradigm is tumor treatment does not influence survival. The horse is bolted when you see the patient. Again, we think it is wrong. There are some patients where early treatment may save their life. And finally, there's no indication for neoadjuvant treatment in patients at risk. Well, that may be correct today, but there may be neoadjuvant treatments just around the corner, and we need to be prepared for that. All of this would involve a biopsy. You cannot sort of solve these problems or challenge them without biopsies. Now, look at these small lesions here. No expert on the planet can tell you definitely this is a melanoma, yes or no. Even with OCT and modern imaging, we would struggle to make the correct diagnosis. Are these chronic lesions as well that have some drusen, some other signs, they're not growing or growing very slowly? Are these really melanoma, yes or no? Well, we biopsied all of these tumors. All of them were actually melanoma, and all of them with monosomy 3. So that puts you in a difficult situation as a clinician. In this case, for instance, if you don't know what it is, you haven't done a biopsy, if you treat it, the patient is guaranteed to lose central vision, and you may totally overtreat this patient. On the other hand, if you now know it's a monosomy 3 tumor, would you be thinking it's worth treating losing vision because it may reduce the risk for metastatic disease? Difficult questions to answer. We looked at all our biopsy patients, large and small, and these are survival curves. So as one could imagine, if you have a disomy 3 tumor, large or small, you see them in the bottom lines, your survival is much, much better. However, we found a significant difference between large tumors with monosomy 3 and small tumors with monosomy 3. Now you can argue it's a length and lead time bias. I would recommend to read this publication where we argue this is not the case. There is a difference, meaning early treatment is very likely to save some lives in these cases. And as you probably heard earlier today by Paul Nathan, this is his work on tebentafusp. There now is a treatment that for the first time makes a difference. And the next step obviously would be if we pre-identify patients at risk with a biopsy and have them undergoing neoadjuvant treatment, we again may save some lives in these cases. Now coming to the Ocular Oncology Unit in Liverpool, we're one of 4 centres in the UK. And these are referrals over the past 3 years. A dip with the COVID crisis like everywhere, but we see about 1,000 new patients a year, of them about 300 with a intraocular melanoma, and we perform between 60 and 90 biopsies per year. What are the indications? The most important one is prognostication in 77%, meaning we made the clinical diagnosis of a melanoma and we want to find out is this a high risk or low risk melanoma, and we do this biopsy after the treatment then. The outcome then will say if you don't have a biopsy, you can only give a vague sort of prognostication, what is going to happen, what is the risk for metastatic disease. And if you do a biopsy, have a disomy, you can tell the patient this is the risk that corresponds to the normal population, or if you have monosomy, unfortunately this is the risk, and that gives them at least the knowledge and relieves the uncertainty if they wanted to know. We do prognostic and diagnostic in small tumors, as you've already seen. It's monosomy 3, small melanoma. And there's sometimes melanocytic lesions where you really don't know what this is. This unusual presentation, lot of exudates. We weren't quite sure. We thought it's a melanoma. We treated it like one, but also performed a diagnostic biopsy for the patient. Indeed, it was an unusual presentation of a choroidal melanoma. Or this diffuse swelling around the disc at the posterior pole. We really did not know what this lesion was. Biopsy showed it was acute myeloid leukemia. Another group in 6% are lesions that we think are metastatic, but there's no known primary tumor for the patient. Then we usually shortcut the diagnostic process by doing the biopsy, which will often reveal the source of the unknown primary. And finally, in about 6%, if we suspect lymphoproliferative disease, vitreoretinal or choroidal lymphoma, there's about 6% of our biopsies. How do we do them? The technique, it's transscleral in 11 and the vast majority transretinal, which I will talk about in greater detail. Just briefly to the transscleral, we only do that in anterior tumors and those that have been treated or immediately to undergo treatment, because if you open up the channel to the surface of the eye, this is where tumor cells grow. You check that you have a biopsy. We use tissue glue to seal it so the tunnel is closed for the cells to get out of the eye. As I said, we like not to do this as purely diagnostic, but only combined with treatment, because otherwise the risk for seeding is very high. The transretinal approach is usually a 3-port vitrectomy setup, and what we do is we put a 3-way tap into the cutter line. Then we go inside the eye. We do not do a vitrectomy. We poke through the retina, get a sample out of the tumor, go out again. There's no tamponade, no laser treatment. And then we flush back via this 3-way tap what's in the cutter. You cannot suck it up. It's much easier to flush it back in there. We remove the trocars. There's no cryotherapy or other treatment there. Just a couple of results. We looked at our last 100 cases in small tumors, less than 2 millimeters thickness. We got a histology result in 85% of these cases. All of these were melanoma. So I think we totally underdiagnosed small melanoma in the past. And just looking at the learning curve, our overall results over the past years have improved significantly. We're now really getting close to 100% histology result. In almost every case, we do a biopsy, even in very small tumors. Looking at the genetic result, we only do a genetic result when we have a histology result, and this is a lower success rate. We're getting better, but still not quite there. Again, one thing to point out, monosomy 3 in 11 of these very small tumors already. So in tumors of less than 2.5, it's now 20% monosomy 3. Again, we think this has been totally underestimated in the past. Looking at the learning curve, unfortunately not as good. We're working on it, but we are not at 100% success in getting a genetic result in these small lesions. So what are the complications? In daily life, the biggest problem is no result. The patients are rather sort of putting up with a surgical complication than with the news. We went through it and they wait for the phone call and we got no result. So now we quote a failure rate of about less than 5%. And no genetic result less than 10%. These are our standards at the moment. The biggest complication in daily life from a surgical point of view are hemorrhages, vitreous hemorrhage in 13%. And you should not underestimate this biopsy. A subretinal hemorrhage can be disastrous, like in this case. you can see a subretinal hemorrhage after the biopsy. So the patient needs to be consented that this can happen, in particular in tumors close to the fovea. And we see this in about 8% of cases. And we try everything to avoid it. This is another surgical video, 27 gauge. We poke through and look at when we remove the cutter, you need to be prepared. It may start bleeding straight away. So what you need to do, you need to hover over it and use the cutter as soon as you see the bleeding, like a finger tamponading it. And then you put the pressure up and wait for the bleeding to settle. So we're really absolutely meticulous in doing that. You still have some cases with a hemorrhage. Retinal attachments surprisingly low, only 1%. Like in this case, a detachment inferiorly. Is it exudative or is it rhegmatogenous? You need to really have a good examination with this, and this is the biopsy side. We had some fluid trickling down from that biopsy side. But in general terms, it's quite surprising how few retinal detachments you get. This is an OCT of a biopsy site postoperatively. The retina is attached, mainly through 3 factors. Number 1, the vitreous is still attached in most patients, so no fluid really enters through the break. Number 2, tumor often is like an autobuckle. And number 3, the radiotherapy that is performed in most cases will cause a chorioretinal scar and seal the break. Rare but very serious complications are a potential seeding to the surface. We fortunately have not seen that over the past years, but during the early days we saw a couple of cases of this. So this is why, if at all possible, we try to do the biopsy after radiotherapy and not before, and try to limit and really fast track for treatment the patients that undergo a purely diagnostic biopsy, that there's not much of a delay between the diagnostic biopsy and the treatment. Another devastating complication can be endophthalmitis. We've seen 3 cases. Fortunately, all sort of had a good outcome with early treatment, but this is something you need to be aware of, because you don't do a vitrectomy, so you have the potential of the vitreous poking through the conjunctiva and making an entry site for any type of bacteria from the ocular surface into the intraocular space. What are the limitations? Well, you need surgical skills. This is not for everyone. You need to be able to do these biopsies and the hemostasis with the adequate techniques. You need lab skills. This is all you get. A little bunch of cells there, not more than that. And you need to be able to process them appropriately for histology and genetic testing. And you do need the pathology backup. There's absolutely no point sending that to your routine pathologist if they're not specialized in cytology. They will not make a call on these cells. So you do need a particular pathologist specialized in making the diagnosis and the call on these very, very small specimens. When are we surgeons sort of thinking of perhaps not to do a biopsy? We don't have any restrictions, so we offer it to any patient, but obviously some cases are really difficult. The most difficult actually are the ones at the disc, because you got these big blood vessels and you need to poke your cutter next to them into the lesion. We pick a spot away from it if at all possible, as you can see there, and it may work all right. And from the size point of view, we're getting a little bit twitchy if it's less than 5 millimeters from side to side, or less than 1 millimeter in thickness. Again, we still can do it. You can see the biopsy site there on the OCT as well. You can see what a thin tumor this is, 0.5 millimeters really. We still got a result, but this is sort of pushing the boundaries really here. But the biggest limitation from my point of view is the effect on the patient, the psychological impact. Because if you get the result that this is a high-risk tumor, it may really be a life-changing event, not only from the metastatic disease point of view, but from the psychological point of view when you get that result. So you need to be prepared, and fortunately we do have some support in our unit. You have to have a risk-benefit analysis. It really, at the moment, is for information only. It does not change the treatment in most cases. So you really have to think fast and long and hard to see whether a biopsy with the potential risks really is indicated. And at the end of the day, we never try to talk a patient into it. It is always patient's choice. And thank you very much for your attention.
So we're going to move on to the next talk, which is from Dr. Rod O'Day, who's an ocular oncologist with whom I work in Melbourne. As I mentioned before, we've been rapidly introducing tumour biopsies in Australia, and particularly in Victoria, over the past few years. And today, Rod's going to present an audit of our uveal melanoma biopsies, for which we've been assessing the biopsies with histology, cytology, and genetics. I'll hand over to you, Rod. Thanks.
Thanks, Dan. And this follows on very well from Heinrich's talk. Heinrich very eloquently discussed why we do these biopsies. And the technique that I'm going to be talking about is a transscleral biopsy at the time of plaque brachytherapy. So in Melbourne, you've heard that we've got myself, John, and Daniel. So I came back in 2020, Dan in 2018, and John a little while before that. The people who do the cytology and the genetic analysis, so it's Penny McKelvie and Svetlana Sherepinov in Sydney, and it's really their team up in Sydney that have taken over and assessed the whole specimen from February 2020. So without their work, none of this would be possible. We talked, Heinrich has talked about this. I think that just to illustrate why things are, why it's so important to understand the genetic makeup, some figures are quite useful. And so this is work that's come from Liverpool and from Bertel D'Amato and Heinrich's team, and they've really been the ones that have led the way in figuring out what the prognostication is based on just using simple things like chromosome 3 status, age, and size of tumour. So if we just know that data, how old our patients are, how big it is, how wide it is, and what the chromosome status, chromosome 3 status is, we can really quite accurately give patients information about whether they're going to develop metastatic disease. So if we look at all comers, so we don't know whether they don't know the status of chromosome 3, and this LB, that means if it's less than 10 millimeters across, all comers, the chance of developing metastatic disease is 6.5%. If you know it is reassuring, so disomy 3, no patients develop metastatic disease. But if it is monosomy 3, so high risk, 1 in 4 will. So that information, if the patient wants it, can be that's very powerful. And similarly, if we look at bigger ones, so this is 14 to 16 millimeters across, all comers, it's 43%. But then if you have a disomy tumor, it's right down at 5%. And then if it's a monosomy one, there's going to be, there's an issue with this just based on the age, but it's much higher. So the types of molecular analysis in the States, it's largely gene expression profiling. Here we look at chromosomal instability. In Sydney, it's a SNP array. In London, where I trained, it was FISH analysis. And then next generation sequencing is being developed. And that I think will be talked about later on. And this is just to mention that from February 2020, this has all been done in Sydney for us, with the cytology and the genetic analysis being performed in the same place because the samples are very small. So our surgical technique is essentially, so we do fine needle biopsies through the wall of the eye, and just looking at really posterior ones. So when you pass a needle through, we saw in the video from Heinrich, they make a flap and then the needle goes through. We don't actually make a flap in most cases and just pass a 25 or 23 gauge needle obliquely directly into the lump and take some cells, put it in a small volume of RPMI media and send it to Sydney. So it's really about choosing the tumours for us. This one's right down the back of the eye, the one at the top, and it's very thin, so we wouldn't be doing a biopsy on that. But this one below is right at the front of the eye, and it's probably 4 or 5 millimeters thick, and that would be amenable to biopsy. At the moment, we aren't doing the transretinal biopsies that Heinrich described, but just the ones through the wall of the eye. Again, showing that these thin ones, the under 1 millimeter, not including the sclera, wouldn't be amenable. But a tumour like this at 6 millimeters would be the type of one that would really want to offer it to. So this is our experience. It started in 2017, and so we've now been doing it for 5 years. Wanted to think about how accurate are we and what sort of complications are we seeing for our patients so that we can give them accurate information. So these patients all had ciliary body or choroidal melanomas, biopsy at the time of the plaque insertion, treated in those years, and at least one postoperative visit so that they could be assessed for complications of the biopsy, and over 18-year-old. So we've done 47 biopsies in 47 patients. The average age is 65, 55% females. It's right and left about the same. 4 out of 5 in the choroid, 1 out of 5 in the ciliary body. And almost all of them are for primary treatment. By that I mean that it's the first treatment for that particular cancer. So the thickness, so the average thickness that we do this for is 5.6 millimeters thick, and the basal diameter is about 12 millimeters. And this is just a plot with their AJCC stage. You can see that across there, most are 2As and 3As. Most of the patients have pigmented tumours, and that's because they're the ones that we can be most sure exactly where the centre of the tumour is, because its location is identified by shining a light through the pupil, and there's a shadow on the outside that we see. But there was also 10% of patients were amelanotic. And then the location, most of them are pre-equatorial, as you'd expect, so towards the front of the eye, where it's easier and safer for us to do the biopsy, but still 1 in 5 were in the macula. So this is just looking at, this is not an example of one we biopsied. So if this is the fovea, the nerve, and the equator is about here. So when I say pre-equatorial, we're meaning lesions up in this sort of area over here, not the ones right down in the nerve, but there was a couple of patients one who was in the nerve, and 20% were within the macula. The average distance to the centre was 8 millimeters, which is about here, for example. Similar, so our biopsy technique, we've had a few different techniques. 85% at transscleral fine needle aspirate. So this is what it looks like. And so we shine a light through and see the shadow of where the tumour is, and we can be very accurately place the needle in the centre. One patient had a trapdoor biopsy where there's a scleral window created, similar to what was shown by Heinrich. 6 patients, we made a small hole with a needle and then used forceps to take the biopsy, and that's all. Complications that we've seen. So in terms of patients, we had all comers. We had patients, so 4 patients, or almost 10%, had a reduced vision by 2 lines in the first 3 months after the biopsies, but only one of those was biopsy related, and this is a patient who had a non-clearing vitreous hemorrhage, and that patient opted not to have a vitrectomy because of their age and medical comorbidities. So there were non-biopsy related reduced vision, so cataract, exudative retinal detachment due to the ongoing exudate from the tumour, and corneal edema. Almost 20% of patients had a short-term complication. Almost all of these were vitreous hemorrhage, and one of those patients had a retinal perforation that we could see, and this is lower than the published literature on that, which has a vitreous hemorrhage rate often about 40 to 50%. There was one patient who had a retinal tear. The retinal tear was distant to the biopsy site, and they needed surgery for a retinal detachment. So this is just showing a photograph of the patient that had a retinal perforation. You can see that's where the needle went, a little bit of hemorrhage on the surface, and it self-tamponaded and did not require any treatment. There's one patient that had extrascleral extension that was not present at baseline at what looks like the biopsy site. And in terms of, and again, this is a known issue, and we'll just need to keep monitoring for this. In terms of vision, essentially vision stayed pretty stable after the radiotherapy, and the follow-up was 16 months. Diagnostic accuracy. So we had 2/3 had diagnostic cytology. That's when we look at the cell type, and then in terms of molecular analysis, 60%, overall 60% had sufficient DNA. So we got an answer from that. So 2/3 from cytology and 60% for the molecular analysis. And I couldn't find a reason why, in particular, some patients had a sufficient DNA for a molecular analysis and others didn't, including tumour features, where it was, whether it was early in our experience or late in our experience, and also whether it was when we had two centres, or one centre doing the cytology and then the other doing the genetic analysis compared to when it was combined. So it looks, so nothing significant, but it does look like as we're doing more, we're getting better at getting an answer. So of the first 25, less than 50 or 50%, we got an answer, whereas in the last 22, almost 3/4 have. And comparing us to other centres, similar, essentially. Perhaps we have a lower rate of vitreous hemorrhage, but it shows that that centres can take up a new technique and do it in a safe fashion for their patients, I think. And this is just showing an example of extrascleral extension. In terms of diagnostic accuracy, at 60% is probably a bit lower than some of the other published reports, but hopefully this will be improving as we do it more and more. These are some of the next steps that we'll be thinking about, the techniques to improve our diagnostic accuracy. So that's been in having it in the same centre, and working closely with our pathologists up in Sydney. And then I think that our next big step will be doing these transretinal ones. Thanks very much.
Thanks very much, Rod. That's very informative, I'm sure, for everyone. And yeah, it's been encouraging for us, certainly in the past year or so, that our yields do seem to be improving compared to where we were a couple of years ago. I've seen Professor Heimann's just joined on the panel. That's perfect timing, Heinrich. Appreciate you joining. It's very early, I know. I actually just, I've got a couple of questions on my mind, actually. So we've seen that for the transscleral biopsies that you tend to do them as a sort of trapdoor or scleral window biopsy. Have you found that the yield from that technique is better than doing just a needle biopsy?
Oh, definitely. The problem about the needle biopsy is as soon as you sort of use the cutter with the transretinal biopsies, you realize how different the tumors are in their consistency. So some are like mushy peas, and it's very, very easy with a needle to get the sample out of it. And some are like leather. And even you're in the tumor with a cutter for about a minute, and you don't get anything out of it. So this is why in some cases with the fine needle aspiration biopsy, I think you don't have a chance to get any material out of it, because as it's like poking a needle into leather. It will not work, and this is why we went to the biopsies either with the forceps or with the cutter.
Okay. Thank you. Interestingly, just in the audit just presented then, we had about a 50% monosomy 3 rate in our biopsies. I know that you mentioned in your talk about a 10% rate in the smaller tumours. Have you found a strong correlation between the size of the tumour and the rate of monosomy 3 in the biopsies?
Well, as I said, we just looked, we haven't published it yet, but we just looked at our 2.5 millimeter tumors, 20% on monosomy 3. I never ever thought that would be the case. I would have thought perhaps 2%, 5%, something like that, 20%. So without knowing, I think we were a little bit too pessimistic about what we're doing. I think we saved a lot of lives in the past by treating these patients early, not letting them grow. But, you know, in these small tumors I showed you, who would have thought that 1 in 5 would have monosomy 3? Not many people around the world, I don't think. So that's really surprised with our biopsy results.
Well, that certainly seems to be a very, very strong trend in ocular oncology at the moment, is that we really do need to be treating smaller tumors more
yeah,
often.
no, absolutely.
Yeah.
It's a complete change. When I started 20 years ago, people thought the horse is bolted, and there's still ocular oncologists saying the horse is bolted. Whatever you do, you cannot save lives. And I think this is true for a lot of cases, for the majority of cases, but there are some that I hope I could show you. All these small tumors, monosomy 3, if you treat them early, you can save some lives.
There's a question from Damien Key for you, Heinrich. In the data set, was it correct that the histology was melanoma in 100% of cases? And what's the implications of that?
Yeah, so we've done now more than 1,000 biopsies over the last 10 years or so, and I can remember 2 cases of a nevus. I mean, Sarah is going to join later, and I understand that there is a bit of a discussion in the pathology community. How sure are you what's a nevus, what's a melanoma, on a couple of cells only? And that's a difficult discussion. But, you know, of all of these, you would have thought you have a lot higher rate of non-melanomas. And almost all of them that we biopsy that have the risk factors of orange pigment or fluid, the really risky ones that we think are melanomas, all of them are melanomas. I think it's, to me, it was a revelation really that most of these ones with the risk factors actually are melanomas.
There are lots of patients coming through. So lots of questions coming through.
Yeah.
Several about just the sort of diagnostic issues with the histology and genetic testing and fish testing and things. Probably not so much specific for you, Heinrich. But,
no, I'm very happy to pass that on to Sarah later.
Thanks. Good. All right. Would Penny, if you're still available there, Penny, are you able to comment on the use of biopsies in enucleation versus the needle biopsies? I think you might have addressed that briefly before. That's okay. There are a couple of questions about diagnosing melanoma with immunohistochemistry or immunocytochemistry. I think for a lot of cases the diagnosis is made just on the appearance of the cells or the tumor, and the additional stains with antibodies, etc., are more sort of supplementary regarding prognosis.
I think Sarah just joined us. Perhaps Sarah can answer that, because, you know, this is not my expertise. I'm just the plumber. I'm getting the cells.
That's right.
So so the diagnosis is Sarah's sort of field. Sarah, do you want to answer that?
Hi, Sarah. I don't know whether you've managed to see a few of the questions on the chat, because I think you've logged in as a panelist.
Yeah, I'm not sure whether you can you hear me?
Yes.
Okay. Okay, so sorry, now I'm allowed to join. So I don't know what questions you would like me to answer. Just to say, with respect to the immunohistochemistry that you just mentioned, usually we don't do immunohistochemistry on the with tiny intraocular biopsies. You can usually tell in the vast majority of cases that these are melanomas just on the basis of the cytomorphology. And if we are in doubt, or if there is a question, a clinical question, is it melanoma or metastasis, then yes, we do the immunocytology, but we tend to reserve all of the material where possible to do the molecular analyses. And we don't do fish, we do the DNA-based molecular tests, so either the MLPA, which looks at the chromosomal alterations, particularly chromosome 3 and chromosome 8. Or if there is only a tiny portion of cells and a small concentration of DNA, then we use microsatellite analysis. We have developed a next generation sequencing panel, which also looks at particular mutations. But this is in the process of being validated for introduction into the NHS. And we have to go through several bureaucratic hurdles before we can get it in, but it's nearly there, so that that we'll be moving on from MLPA to this next generation sequencing panel, which is bespoke for uveal melanoma. So I don't know whether I've answered quite a few questions in one go.
Thank you. Thanks, Sarah. We had a question from a participant who underwent an enucleation several years ago and had pathology done with a FISH analysis, and was wondering whether there'd be a role for having additional tests performed on that specimen, and whether that would be helpful for her management at this stage.
So I guess it depends on the result, but it is certainly possible from the enucleated eye, from the formalin fixed paraffin embedded specimen, to extract DNA and do either MLPA or also the mutational testing. You can also do, and I'm sure Penny probably does this, you can also do the BAP1 immunohistochemistry. We regularly do that on all enucleated eyes, and if the BAP1 immunohistochemistry is very good as a surrogate marker for the status of the BAP1 gene. So if you have nuclear loss of the BAP1 expression, then that typically means that there is a BAP1 deletion or BAP1 mutation, and so they tend to be high risk.
The questions disappeared from the screen, but I believe in this patient's particular case that we already have the demonstrated loss of the chromosome. We already have the demonstrated monosomy 3 or loss of the BAP1 protein. So I suspect, knowing that already, there's probably not a very pressing need to obtain further information right now. But it does highlight that it is important for us, where possible, to preserve specimens, because over time we may be able to glean significant further information from the biopsies that may affect treatment significantly. Yeah.
And I'm not sure whether Heinrich mentioned it, but we have this prognostic algorithm called LUMPO, where you combine the age, the gender, the location of the tumor, the size of the tumor, the molecular genetics, and so for each individual patient you come up with prognostic curves, and these are also very helpful, I think, when speaking with the patient, and in terms of their individual risk of developing metastases versus sort of a general risk. But he may have mentioned that, and those patients who would like to know that information receive that together with the clinical team, particularly with the clinical psychologist. And also on the base of that, there is the stratification of the liver surveillance, either using MRI or ultrasound. For MRI, obviously, for those patients at high risk, and ultrasound with those at low risk. And the regularity of the surveillance is also varies according to the risk, metastatic risk of the patient.
Thank you. The questions are still coming through thick and fast. I think we do have the next session scheduled at 3:15, but I think it may be worthwhile just persisting with a few more questions, if that's okay with the organisers. We have a couple of questions for Heinrich again. In intermediate or indeterminate lesions, Heinrich, do you take any precautions to prevent seeding at the time of biopsy, given that you won't be plaquing them at the time of the biopsy?
Yeah, that's a very good question. So we have cases where we're not sure, or the patient would not have, doesn't want any treatment without the absolute confirmation that this is a melanoma. So we do some biopsies in untreated, and we fast track them, meaning Sarah is on red alert. We want a result straight away, and we basically schedule them for a biopsy, let's say on a Tuesday, and for a treatment slot a week later. So we don't spend too much time in between biopsy and treatment. So if we suspect it's a melanoma, say biopsy on Tuesday, and then a plaque or proton beam radiotherapy in the weeks after. We don't like to do it because seeding is a real problem. And the melanoma cells, if they're inside the eye, in the vitreous, in the retina, they don't seed much. That's not much of a problem. There are very few cases. However, as soon as they're in the anterior chamber or on the ocular surface, on the conjunctiva, they grow straight away. And if you seed a melanoma into the conjunctiva, it's a disaster. It's sometimes you get away with treating it locally, but in the worst of cases, you end up in an exenteration, in a small tumor that you seeded to the ocular surface. So it's not what we really like. So in these cases, if we're not sure, we usually then go back to the old days where we say, look, if it's growing, we see you again in 3 or 4 months' time. And this is our diagnostic approach to diagnose a melanoma in such cases. So we try to avoid it, but we have one, I would say, every 3 or 4 months where we biopsy an untreated tumor. And we're super careful about that because there's nothing more that I fear other than endophthalmitis is seeding of the tumor with a biopsy.
Thank you. I think we've covered almost all of the questions. There are a couple of outstanding issues regarding the pathology, but I suspect we may be able to address that following Sarah's talk. So we might take a break for 10 or 15 minutes. So let's plan to reconvene at 3:20, if that's okay. So let's take a quick break. Thanks, everyone. Thanks to the speakers again. It's great.